Lung infections. I'll talk very quickly about tuberculosis at the end, but the main thing I want to talk about is pneumonia. Okay, it's defined as infection and inflammation of the lung parenchyma, and the most common pathogens are bacterial, and we'll go through each of those and some of the antibiotics you might want to use. When you look at someone with pneumonia, try and identify host and pathogen factors that may have led to the cause of the pneumonia, and we'll go through that in a second. So they could be immune-related, the host, or they could be non-immune related. So if they don't have an immunodeficiency, they could have a mechanical deficiency. We saw the X-ray earlier, the lady with cartilaginous syndrome who has the cilia that don't work. They get at risk of retained secretions, and they may develop a pneumonia more easily. Likewise, those with cystic fibrosis are more prone to lung infections. Also, it's related to the pathogen. So if you've got a very virile pathogen, then that's going to produce a pneumonia in someone who may be immunocompetent. And also the size of the dose. If you get one bacterium come in, it's unlikely to cause a pneumonia, whereas if you're sat next to someone all day with a virus, then you're more likely to pick up that virus. And again, we'll see that with TB. The biggest risk factor for TB transmission is how long you spent with someone who's smear positive. And there are various methods of spread of pneumonia. The most common one we think of is where the pneumonia is spread by droplet transmission in the air. So you breathe in an inhaled bacteria. It can also be caused by aspiration of your own nasopharyngeal or gastric flora. So you give it to yourself. And you see aspiration pneumonias in people with neuromuscular disorders and such things. Also, it can be spread hematogenously. I said that right. And what that means is it's come from somewhere else. If you've got a septic arthritis, perhaps with Staph aureus, or you've got endocarditis, then that may spread to the lung via the blood if you get a septicemia. So there are the three ways that they can be. The most common probably transmission through aerosol. And there are various different types. Community-acquired, hospital-acquired, that's probably the biggest distinction. And different pathogens, viral, fungal, and aspiration, as we will speak about later. And empyema is an infected fluid within the lung, the pleural space. So community-acquired pneumonia does exactly what it says on the tin. It's pneumonia that's acquired in the community. And these are the most likely organisms to get. These are prevalence of organisms with community-acquired pneumonia, and by far the most common is Streptococcus pneumoniae. Chlamydia pneumoniae, it's not the chlamydia that young students like yourselves may get. It's a different chlamydia. That's true. And that's 13%, but it does tend to happen in young people and can present atypically. Mycoplasma pneumoniae, again, happens in young people. There are epidemics every 4 to 5 years and presents more with a headache and things like that. Haemophilus influenzae we saw as a major cause of COPD exacerbations. Legionella is the one, when they go to Spain and they stay in a dodgy hotel with an air conditioning unit. It's the one that lives in water. So you can get that if you've got poor air conditioning units and stagnant water lying around, you can get Legionella form. Chlamydia psittaci, that's the pigeon you get from birds. Staphylococcus aureus, 1.9%, and Moraxella catarrhalis. Remember, that's probably a bigger cause of COPD exacerbations than pneumonia. And viruses account for around 12% of pneumonias. The atypicals are the Mycoplasma, Legionella, Pneumocystis, it's now called Yarovecki. It used to be called Carinine pneumonia, and Coxiella I can't really say that, Bernetti. Causes Q fever, and this is vets get this and people who handle animals and things like that. Hospital-acquired pneumonia is defined as a pneumonia after 48 hours in hospital, and this can be classified again further into early and late onset, and the cut-off there is 5 days. So early if they've been less than 5 days, late if it's over 5 days. The reason we make this distinction is because there are different organisms in hospitals that cause pneumonia. They're likely to be more resistant to medications we usually use, and they're associated with a greater mortality. Late hospital-acquired pneumonias are again associated with more resistant bugs, and we need to treat them with different antibiotics. There's a lot more gram-negative organisms, such as the E. coli and lots of other things that we need to give them a broader cover of antibiotics. But other common organisms are Staph aureus, whether that's methicillin resistant or not, Klebsiella, Legionella, and Pseudomonas can be prevalent in those with chronic respiratory disease. Aspiration pneumonia is aspiration of gastric contents, and this can happen in people with neurological reduced GCS. So if you've got a chronic neuromuscular disorder that can cause you to aspirate. You've got a poor swallow and you end up aspirating your own gastric contents, or people with stroke, or people who are unconscious for any length of time. And if you do get aspiration pneumonia, we need to cover for the anaerobes, and one of the things we can do with that is give them some metronidazole. That works quite well. You want to give them IV therapy, and you want to prevent the recurrence. So you want to think about why they had an aspiration pneumonia. If it was a one-off event, like they had an epileptic fit, for example, you want to prevent those epileptic fits and avoid aspiration pneumonia. So history, again, it's for our normal pneumonia, so fever, rigors, cough, sputum production. They get pleuritic chest pain. That's chest pain that's worse on movement and inspiration, and they'll be breathless if some of their lungs taken out of action by that consolidation. Aetiology. You want to decide what organism's causing it. Is it bacterial, is it viral, or is it an opportunistic infection like fungal pneumonia in someone who's immunocompromised? Try to ask them whether they've done anything different recently. Have they done any work in the garden? Have they been on holiday to a dodgy Spanish resort, or something like that may elude you? Have they been to an area of the world where there's a different prevalence of organisms and things? So that's important to ask them as well. So any recent travel. And try to work out the mode of spread, as we said before. Is it likely aspiration, or is there something else going on? Do they have evidence of a septic arthritis that may have this systemic infection going on, seeding it everywhere? And try and decide whether they're gram-positive or gram-negative organism. And for this, I'm going to refer to a concept I call data mining. And this is, you kind of realise when you start hospital medicine that some people don't give the most brilliant histories, and there's a lot of information that you already have in the old notes on previous systems, the X-ray systems, previous discharge summaries, and previous results. So you want to look through previous sputum cultures, things like that. And also look at their conditions. If they're known bronchiectasis, they might have different organisms to whether they're not. So you want to, what I call data mine, is once you've taken your history, go and look for absolutely anything and everything that you can get your hands on in the hospital to try and decide what's going on with the patient. There may be community-acquired pneumonia, but if that patient has known to have resistant organisms in their sputum time and time again that you can see on the system, you're going to want to be thinking about giving them different antibiotics. So try and get that information if you can. And it's becoming better now that we've got sort of more electronic resources in the hospital. Think about host factors. Why has this patient got a pneumonia? Especially in young people, or is it related to chronic respiratory disease? So look at their comorbid conditions. Have they got heart failure? Have they got COPD and pneumonia on top of that? What's their physiological reserve like? And again, that's probably related to their comorbid condition. Any chronic respiratory conditions? Do they have any potential for complications of a pneumonia? Are they going to go into heart failure because of pneumonia that may cause an arrhythmia? Patients with pneumonia are always flipping in and out of atrial fibrillation. And that may make more sense when we learn that atrial fibrillation originates from the pulmonary veins. So if someone's got anything wrong with their lungs, often they flip in and out of atrial fibrillation, especially when they're unwell and septic. Do they smoke? That's a risk factor. And what's their usual exercise tolerance? That may give you some ideas the sort of status of this patient. And then think about, have they got any reason to be immunosuppressed? And they on any drugs that cause immunosuppression? And the list is endless of drugs that cause immunosuppression. So try and look at the drug chart and think to yourself individually, are there any drugs or medications here that may cause immunosuppression? It may be intentional. There may be a transplant patient receiving immunosuppression for that reason. They may have cancer and they're on drugs that cause immunosuppression as a side effect. They may have HIV, and if someone presents with lots of infections, it's becoming sort of more prevalent in London at the moment and in some areas of Essex that I know of. So HIV is an important diagnosis to consider, and there are new guidelines on who we should and shouldn't test on that now that you can look up later. And is there a hematological malignancy? So we want the full blood count as well to check that. On examination, look for signs of sepsis. And the signs that you're going to see are maybe tachycardic, hypotensive. When you've got someone who's tachycardic and hypotensive, try and look at their peripheries and say, are they warm or they're cold? If someone's tachycardic, hypotensive, that could be that they've got reduced cardiac output because of cardiogenic shock, or it could be that they're hypovolemic. But if you've got warm peripheries, that suggests you've got a vasodilatation going on, and you're more likely to see warm peripheries in someone who's septic. So hypotension in someone with warm peripheries suggests sepsis. Okay, reduced consciousness, and they may be febrile, so they might have this pyrexia that you'll be able to detect when you get your observations done. Look for signs of hypoxia. Again, tachycardia is one of them, so most patients come in with a tachycardia. They'll be short of breath and they'll have a tachypnea, and they may have reduced consciousness because of the hypoxia, not getting enough oxygen to the brain. So chest signs of pneumonia. On inspection, we're going to probably see, if there's a large lobar pneumonia, you might see reduced expansion on that side, and they may be in respiratory distress, and you might see intercostal recession and very rapid breathing rate. There may be reduced expansion on that side. And areas of consolidated lung transmit sounds, because sounds transmitted better through solid than in air. You might see increased tactile vocal fermentus, but very hard to pick up. And sometimes you can feel it, but it's something you probably have to actively go and seek out, and you probably have enough information to make a diagnosis without finding that, but it's a nice clinical finding to discover. Over the area of consolidated lung, if they've got lobar pneumonia, you may get a dull percussion note, and you may hear crackles. That's probably one of the most, it's not very specific, but a lot of people with pneumonia do have crackles. Absent breath sounds, bronchial breathing. Again, we said that sounds are transmitted better through solids than in air, so bronchial breathing is a sign of consolidation. So you should check for that as well. And it just sounds like, if you get your stethoscope and listen over your trachea, that's what bronchial breathing sounds like, and you'll hear it, and it'll be much different to the surrounding lung that doesn't have consolidation. Whispering petriloquy. Ventriloquism. Vente means stomach, and triloquy means projecting. So ventriloquism means the stomach speaking. This means pect. Pect means chest. So this is the chest speaking. So if you get someone to speak, because you've got an area of solid, consolidated lung in between you and the airways, you'll hear this very, very clear. That's really nice to pick up as well. So whispering petriloquy, important one to look out for. But not going to add very much to your diagnosis. You probably have your diagnosis already by then. Investigations. The two features we want new consolidation on a chest X-ray. That's why it's important to look back through old X-rays. So when you see an X-ray, if there's an area of consolidation and they had it 3 years ago, it's unlikely to, well, it could be, but it's unlikely to be anything new. But you want to see new consolidation on chest X-ray and biochemical evidence of an infection. So you want to raise CRP or C-reactive protein. Uvex specials are mnemonic for going through investigations. Urine is useful. And you can use it to do various antigen tests like Legionella antigen. Also, you want to check on the urine dipstick that they don't have any blood or protein that may suggest some diseases that like vasculitis, where you also get renal and pulmonary disease. So it's important to look for that as well. You can also do urine antigen for streptococcus. Bloods, you definitely want venous bloods, where you want to check the full blood count, the hemoglobin, and all of the neutrophilia suggests a bacterial process. Lymphocytosis suggests a viral process, and we want to check the liver profile, the renal profile. These are important when we're going to stage the severity of pneumonia. And you also want to check, there's something called procalcitonin. It's not used very much here. It's used in the States, and especially intensive care in the States, and they use that to check when to stop and start antibiotics. So when the procalcitonin falls, they usually stop antibiotics. It's a precursor of calcitonin, as the name suggests. Univariate histological tests in venous blood, Mycoplasma IgM, and there's a concept called acute pneumonia screening. So when someone comes in, especially young people with an atypical looking pneumonia, you do an acute pneumonia screen. So you do Mycoplasma IgM on the serum, you can do Legionella and Streptococcus antigen in the urine, and there's lots of other tests you can do, but they're the main ones. And you want to do cultures, and blood cultures. We also do sputum cultures, but we'll come back to that later. And arterial blood gases are relevant when there's hypoxemia, and you want to check their oxygenation and their ventilation. And also, if they're very septic, you might get a raised lactic acid, and this lactic acidosis is a marker of sepsis. So that's another reason you want to do a blood gas. X-rays, essential. So you're looking for new consolidation on chest X-ray. So you'll want a chest X-ray. So get one of those. Lateral chest X-ray is not done very much, but it can help differentiate which lobe it may be in. You might get a lateral chest X-ray where someone's got chronic respiratory disease and there's lots of complicating features, but not usually asked for. You can do a CT chest, And that can be to exclude, say someone's had a large smoking history and a non-resolving pneumonia. You might think of, is there a cancer going on that's causing all of this? So you might want a CT chest. And an ultrasound may be useful for where there's an effusion. Sometimes people get what's called a parapneumonic effusion, so an effusion around an area of lung that's consolidated with pneumonia. And that's why it's important to examine people daily, especially with Streptococcus. Streptococcus is a very aggressive infection and can jump from lobe to lobe and can cause parapneumonic infusions. So listen to their chest daily, or if someone's in with a pneumonia and they suddenly get more breathless, it could be the pneumonia is progressing and the antibiotics you're using aren't working, or it could be they're developing this effusion, which can turn into an empyema, an infected effusion. ECG you definitely want, because they'll be tachycardic, and you want to know what kind of tachycardia there is. If it's sinus, it's probably an appropriate response to what's going on, and you don't need to do anything about it really other than try and treat the underlying cause. They go into atrial fibrillation, as I said, a lot, so that's important to recognise as well. There are some people do treat the atrial fibrillation that people get when they're well, some people don't. Any special tests? We want to do a sputum culture, absolutely. Treatment is empirical usually, we'll go on to that in a second, but we want to know exactly what bug we're dealing with, so sputum culture is absolutely essential. And if they spike a temperature, this suggests that there's bacteria in the peripheral bloodstream. We want to do blood culture as well. And if they've got any fluid, we want to take a tap of it and send it to the lab for analysis. It may have bugs in it, it may discover something else going on. And when we've got our cultures, we want to look at the sensitivities and resistance so we can give better antibiotics. So first thing to do is assess severity. There is a pneumonia severity index. It's a lot longer than the classically used Curb 65 score. And the BTS have adopted the Curb 65 score because they like it, because it's simple, and I like it because it's simple as well. And each letter in mnemonic stands for something different, and it's confusion, that's a C. U stands for urea, so that's also why we want their U's and E's, because we want to be able to stage them. And if the urea is above 7, then they get a score for that. Also the respiratory rate, if they're tachypneic with a respiratory rate above 30, then they get a score for that. Blood pressure as well, so if they've got hypotension, then they get a score for that. And also whether they're 65 and above. And this is how it relates to severity. If they're a low risk, they've got a low score, there's a low mortality, 1.5% mortality. If they get a medium score, then they get 9.2%, and a high mortality of 22% if they've got a high score. And it impacts on what we do about it. Some people with a low score, because there's a low mortality, they could probably be okay at home. If medium, they probably need to stay in hospital and you need to give them IV antibiotics and observe them. And if they've got a high score, so they're very confused, hypotensive, urea, the kidneys are going off because the urea is up, all of those things, and they're quite elderly, then you're going to want to do some serious things with them and perhaps consider intensive care to try and sort them out. But really, to treat a pneumonia, the two things that you want to do is you want to give them antibiotics and you want to support them. So support their circulation and their blood pressure, and support them with oxygen if they're hypoxemic, and you want to give them antibiotics to treat the pneumonia itself. So again, anyone unwell, move pneumonic. People with pneumonia without chronic respiratory disease, you're going to want a high target oxygen saturation, so 94% and above. I put this up there, 88 to 92, because that's the other low oxygen target saturations for people with COPD who retain CO2. But most of the patients won't have COPD, and you want to give them enough oxygen to get their oxygen saturations above 94. And I've split it into A, B, C, and D, which you'll see time and time again when you're looking at resuscitation. So airway. You can support their airway by ways of tracheal intubation if they're a candidate for ITU. However, this is probably not always necessary. B stands for breathing, and you want to give them plenty of oxygen for sure via an appropriate route, so 15 litres via a non-rebreathing mask. CPAP has been useful in pneumonia and type 1 respiratory failures because it increases their functional residual capacity, opens up more of the lungs so you can get more gas exchange going on. But there are some recent trials going on about whether bi-level positive airway pressure is going to be useful for pneumonia. So we'll wait to see what the guidelines haven't adopted yet, and we'll wait to see what happens. Support their circulation with intravenous fluids to keep them, they're probably not going to be eating very much, so you want to give them maintenance fluids. But if they're very septic, peripherally dilated with a low blood pressure, you want to give them a fluid challenge and keep up with the fluids and monitor their urine output as well. If they're on ITU, they may well receive vasopressors such as noradrenaline, and this causes peripheral vasoconstriction and maintains their blood pressure. And also, you want to, D stands for disability, and with that in most things is glucose control, and adequate glucose control is important. I haven't included everything that appears in a document called Surviving Sepsis Campaign. That's something to look up when you go home. And that outlines all of the things that we need to do for patients with sepsis. So it's a very important document, and I implore you to look at it when you've got some free time. So antibiotics. We're unable to predict, based on history and examination, the kind of organism that we're going to get. We may have a good idea. As I said, when you're data mining, you found out that the last infection this person had Pseudomonas. You may be expecting Pseudomonas in the next sputum. It's entirely plausible and highly likely, but we can't predict. So that's why we want to know, and it's going to take us a while to know until we do sputum cultures and blood cultures and everything else. So we treat empirically. We don't wait 3 days until the culture comes back. We treat them straight away with antibiotics. Empirical means based on experience. So based on our experience of the likely organism. As we remember, 39%, something like that, was Streptococcus pneumoniae, and that has a low resistance rate to penicillin. So penicillin is very effective. So one of the antibiotics we'll give usually in the penicillin if they're not allergic. So based on the severity as well, we're going to treat them with either oral or IVs or different antibiotic regimens. We've said that. So community-acquired ammonia, again, we've said that we can split it into low, medium, high mortality based on their score. And that really governs what we can do. This is a suggested guideline for antibiotics, but really should go in your hospital's microbiology policy. So for a low, just go back one slide. So for a low mortality, we're going to go for amoxicillin if they're not penicillin allergic. If they are, we can use a macrolide such as erythromycin. If they can't tolerate that, then we're a bit stuck. We need to get some microbiology help. If they're medium risk, there's a medium mortality, we're going to use amoxicillin plus something else like erythromycin or macrolide. Or we could use levofloxacin with some of the newer things. Coamoxiclav, rifampicin and macrolides can be used in a severe pneumonia, and these should be given by the intravenous route, preferably. And levofloxacin and benzalpenicin can be used. Ed and I were talking a few months ago, and we were sort of discussing things, and we've noticed that there's a vast difference between different hospitals as to what antibiotics they do and don't want you to use. And they all quote to sort of local sensitivities and resistances as the cause for that, but I'm not so sure. But different hospitals do have different policies, and you should go with your own hospital's policy. This is my hospital's policy, and they split it mild to moderate. We use clarithromycin, and that's half a gram BD orally. And in a severe pneumonia, we add to that benzalpenicillin, and that's given IV. And we can also add rifampicin, which is usually associated with TB treatment. That's what we use at my hospital, and they're all very different. So I don't want you to have it in your head that these are fixed, antibiotics, that you should only be using those. And hopefully your medical school won't be unkind and give you examination questions asking you which antibiotic to go for. But if you do, have a look at the BTS guidelines and have a look at, I'll just go back one slide, these antibiotics, because these are their recommended antibiotics for treatment of a pneumonia. And let's move on. So organism-specific antibiotics, again, you want to weight sensitivities. When you get a culture result back, that's brilliant, because you'll have the sensitivities and the resistance. You'll know what the bug is sensitive to and what it's resistant to. Bear in mind, though, that sample may have taken several days to grow, and it's say 3 days old, and things may have changed since then. You may have a different population of bugs now that may be resistant to some of the antibiotics that original sample were sensitive to. So just bear that in mind. But these are I won't go through these, but these are some of the antibiotics that you'll use in particular organisms. We're going to put this up on the PodMedics website, so you can have a look at those later at your leisure. I just want to say something, because I'm doing renal medicine at the moment. Gentamicin is a very bad idea when someone's got acute kidney injury. So if someone's got either chronic kidney disease or because they're septic, their kidneys are going off, if it's a severe pneumonia, gentamicin can cause a precipitous decline in their renal function. So beware, but again, check with your seniors and check with your local microbiology guidance. you want to monitor their infection and the response to the antibiotics. And you want to do it in various different ways. Procalcitonin they use in the States, but we can look at CRP here in the UK. Also monitor them clinically, and you want to keep a close eye on them. And you can do arterial blood gases if they were in respiratory failure to check their oxygenation and ventilation. And look at their physiological status. So look at all of the observations. How often are they spiking temperatures? You should usually continue antibiotics for about 5 days, or say 24, 48 hours since the last spike of fever. And if they don't respond, try and think, why are they not responding? Was your diagnosis wrong? Is this not a pneumonia? Have you got the wrong bug? Are you treating the wrong bug with the wrong antibiotics? That's another reason for things not going your way. Also, pneumonias that don't respond, there can be something else going on, like a lung cancer that's caused a bit of lung collapse, and you get retained secretions behind it, and that can cause a pneumonia. So then you need to start thinking, is there something else we should be doing for this patient? Viral pneumonias, I don't want to spend too long on this. There are lots of different, we've heard recently about swine flu that can cause pneumonias. People can become very unwell, but generally people with swine flu do okay, and they don't require any antivirals. They just feel a bit rubbish for a few days. There's also bird flu before that, and SARS, severe acute respiratory syndrome. And they occur in immunocompetent and immunocompromised, but can occur in immunocompetent individuals. The immunocompromised are at risk of other viral pneumonias, such as CMV, EBV even, varicella zoster, and some of the common viruses like the adenovirus or the rhinovirus, coronavirus, can all cause viral pneumonias. They're usually associated with a higher fever, maybe a dry cough to start off with, and they usually tend to get worse, may become purulent sputum, and they're very breathless, and they can go into acute respiratory distress and need ITU support. There's usually not much to find on examination, I have to say. And investigations, there's not much to see on a chest X-ray either sometimes. Sometimes you can get a mild hazy opacity like a bacterial pneumonia, but not as consolidated. Sometimes you can get perihilar. We'll see I'm going to do Pneumocystis in a moment, and I'll show you an X-ray of Pneumocystis, and you'll see what it looks like a viral pneumonia, even though Pneumocystis I know is a fungus. And treatment is supportive with or without antivirals, but you need to support them. So fungal pneumonias, big topic, lots to speak of, only really happen when the patient is immunocompromised, so either intentionally, like in a kidney transplant patient, or if they're on anti-cancer drugs, or they can occur in hematological malignancies like acute leukemias and stuff. You may get fungal pneumonias, or if someone has any other reason to be neutropenic, or lymphopenic and things. But there's lots. I won't go through them here. So Pneumocystis is probably the one I want to concentrate on most, because it's probably the one you see in exam questions the most. And in my experience, I've done a haematology job, it's the one I saw the most, confirmed cases of Pneumocystis. And this is associated with people with HIV with a low CD4 count, usually below 200. And it can also be associated with chemotherapy and the immunosuppressant drugs, also with hematological malignancies. And it presents with fever, intense exertional dyspnea. So they may be okay at rest, but as soon as you exercise them, then they get very breathless. And they may also have a dry cough. On examination, they may be hypoxemic, but usually this is exercise-induced. That's the classical description. So you put an oxygen probe on them on one of the trolleys, and you walk them up and down the wall, and they become profoundly hypoxemic as they walk up. And they may have other signs that relate to their immunocompromised state, whatever that may be. And here's a chest X-ray. So you want to do a chest X-ray definitely. And here we can see ground glass, perihilar opacities that usually exhibit peripheral, or may not exhibit peripheral sparing, but it's usually perihilar. It just looks a bit, I don't like the word, but it looks a bit fluffy and hazy, but this is concentrated around the hilum. So that's what a Pneumocystis X-ray can look like. It's important to look for as well, you may get ARDS, and that's, ARDS is acute respiratory distress syndrome, and you get opacity all over the chest, and that's one of your differentials in someone who's very unwell. You may see hypoxemia on their ABG or on co-oximetry. And the other thing to do is that these people can be diagnosed They usually don't cough up very much, so you might want to do bronchial alveolar lavage. So they have a bronchoscopy, you squirt some fluid in, you suck it up, and you send that fluid away for analysis, polymerase chain reaction, or however they're doing it. Management, assess the underlying reason for immunosuppression if there is any. Like if they're on immunosuppressive drugs, you might want to stop them. It's a wise thing to do. And there's other causes of immunosuppression I don't want to go into. But treatment is clotrimazole, and it's high-dose clotrimazole. These people are on massive doses of clotrimazole. And clotrimazole is a combination of sulfamethoxazole and trimethoprim. And it's called Septrin, it's a trade name. It's 120 milligrams per kilogram. The usual dose for prophylaxis is like 980, something like that, 3 times a week. But this is 120 milligrams per kilograms in a day in some divided doses, 4 to 6 is the usual. An alternative can be pentamidine, and this can be nebulized or given IV. So that's pneumonia. Another 30 seconds, I'll have a drink, and then we'll do TB. Okay, and then we'll see how you are and whether we can do the rest of it.